So, what we're going to do today, Claire, is we're going to go through the external pelvic floor assessment. And I just want to make a comment here before we get into the assessment. This is an educational video. Claire is totally okay, and we've done this and we've practiced this. So I'm going to run through some of the consent that would normally occur.
Sure.
And then I just want to comment on a few things. So number one, the palpation, the amount of touch might be, it might look like a lot. And, you know, I'll put a picture in the video of where on the pelvis I am and where the pelvic floor attaches to. And it is around the corner of the pubic ramus. So we don't necessarily feel it from the outside. Some people can sense things and we can correlate to see what that means, but it doesn't mean that that's what's actually happening. So it's a correlation thing. So we're going to get up and do it in standing as well. Also, I just want to make note of the fact that this is a limited technique. Okay, so you get different information from the external part. I think the benefit is that we can teach people how to self-assess, and we're going to demonstrate that today. But also that the whole system monitoring can be done, as well as the fact that an internal assessment produces a different feedback into the system, and external can be a different feedback into the system, and the motor patterns might change between the two sets of feedback, and then also when they've got their own feedback, either internally themselves or externally with their hands. What I am sensing for is very, very simple. Are they pushing down? Are they squeezing? Are they lifting up? The lifting up is very, very light. If you cannot feel this, there are many reasons why. And I've felt pelvises that I didn't feel things on, and that's why an internal assessment is really important. So yeah, and you know, this is obviously for health professionals licensed to touch patients. I'm not teaching people out of scope work. It's important to know that this is not a pass-fail thing. This is just more information, and I keep it very, very simple. I'm just going to go through the consent and go from there. And, you know, and the reason why we're doing an external pelvic floor assessment. So, Claire, thank you for taking part in this little demonstration for everybody. You know, from the assessment so far, there may or may not be a component of the pelvic floor contraction and the way that you do it, which may be relevant to your symptoms or your performance that we're looking at. And so I'd like to do an external pelvic floor assessment. And the information that it gives me is very, very simple. It's not the be all and end all, and we don't need to do it. So if you're happy for that to occur.
Yep, happy for you to do it.
Very good, thank you. You can change your mind at any time.
Sure.
Okay, so if you don't like what I'm doing, if it's painful, if you change your mind in any way, you can move your hand, you can just say no, and you are always free to just say stop.
Yep.
Okay.
No problem.
And for those, because you can't see me on the video, not only am I paying attention to where my hands are and sensing, I'm also monitoring Claire, both watching her face and feeling for reaction in her body. And also I would be aware of if there was a potential for any trauma, this may be a triggering event for them. So we've already gone through all of this in the assessment side of things.
Yep.
However, if Claire hadn't told me of an abuse background or a trauma background, but then it comes out, then obviously being ready for that to be an option that might occur is important too. Okay, so what we're going to do is have a feel.
Yep.
My left hand, because I'm sitting on the right of Claire to do the right, my left hand is over the ASIS, and if you just open your leg a little bit, they may be able to see. It's just on the lower part of the abdomen here, just to monitor what's going on. I'm going to find the ischial tuberosity, so I'm going to...
Yep.
And then, now quite often I'll ask people, there's the ischial tuberosity there, quite often I'll ask people to let their knee rest on my shoulder just so that they can relax more, if you're happy to do that.
Yep.
Very good. So just relax there, or let it go there, and then... And so one thing that you can do is find the gluteal fold, and that will help you locate the ischial tuberosity, and that's where it is there. Now, it's different in different people's perineums, but roughly at this point here, you're going to be near the perineal body. You may be further back towards the anus. Very rarely are you going to be at the level of the vagina down here. And I would have to ask Claire where I am, but yeah. And so now I'm going up through the pubic ramus, through here, and I'm staying on the outside of midline. Okay, so I did forget to say in the consent that it is in the groin. The labia are on the midline side of things, and I stay on the lateral side of things. Now there is a palpation technique which is midline, and I'll go through that for the standing video. So here's how it is here. How does the pressure feel for you, Claire?
Yeah, firm but comfortable.
Firm but comfortable, okay. And I'm trying to be broad in my approach. Okay, and then from there, I'd ask Claire to do her usual pelvic floor contraction. So just your normal pelvic floor contraction, and then relax. Good, and then breathe in, breathe out and contract. And the only reason why I cued that is just so that I know when she's contracting, I can feel there's a contraction, breathe out and relax. Good, and I'll give Claire a couple of breaths to relax. I'll resituate. So this is roughly the middle of the pelvic floor, around this sort of area. I can go behind here, this is ischial tuberosity, and then I can go find the sacrotuberous ligament. Now I'm just, oh no, you rest on me, and I'll do that. No, yeah, I can, I can manage it. Sometimes you might have to ask your client to do it. So here, and then you find that sacrotuberous through here, and then we're now into the posterior pelvic floor, and you can go all the way to the coccyx. So the coccyx would be, that's higher than the coccyx, and then you'd come down to the tip of the coccyx there. And so posterior pelvic floor in through here. Okay, and so just let that settle and rest. Rest your leg on me. So put some weight on my shoulder, that's it. And so a different cue was needed for Claire. And so then from there, when you're ready, just do your normal contraction. Nice. Okay, and then let it go. And what really I'm monitoring for is whether they're bearing down or not. That's the main one. So can you do a bear down for me, please? And that's a bearing down. I can feel that I'm being pushed out away from the body towards the camera, and relax. And then squeeze and lift. That's it, nice. And relax. And what's interesting there is that I can feel what's going on in her upper body as well. Okay, now I will go all the way up to here. The other way to find where you are in this position is actually to start with the abductus longus tendon, because that will go to the pubic symphysis. Be careful here because the clitoris is right underneath there, so you would then find the bone, and I'm careful to take tissue from the lateral to the medial to ensure that I don't just pick up my hand and go medial. Okay, so I go in here. And then look, honestly, different underwear styles means that you're going to feel different things. So you have to get past those elastic bands. Now, how's the pressure here?
Yep, the same.
So firm but comfortable?
Firm but comfortable.
Good.
Yep.
And then, so I've got my hand on her abdomen and her hip and her pelvis. I can sense what's going on here, and I've got the anterior pelvic floor here on the right hand side. Do your gentle pelvic floor or your normal. That's it. And so that one felt like a beginning at the back passage up towards the front. And you can ask for a front to back. So think about from the front and go to the back. Yeah, you see that's a different kind of feeling. So you can learn that, and if you can't feel it, it doesn't matter. Very good, thank you. And so that is the palpation there. Now also I asked Claire to do a bear down. We can ask Claire to do a cough, a COVID safe cough. Very good. And so what you can do is to see where she bears down through in different places. So cough again. Good. And it's normal to have perineal descent. So I've already felt this location, and then we would want to feel, so I have to change my angle a little bit. Yeah, up into there. So you would see that I came from the outside and then I came up and medially. Yep. Good. And so there's a lot more perineal descent in the anterior part of the pelvic floor here than there is compared to the middle and the posterior part of the pelvic floor. And that's what I'd ask an internal therapist to look at. And Claire literally got one done the other day, and it confirmed that her strength was stronger in the back portion, and her endurance was better in the back portion compared to the front portion.
Yep.
Very good. So we've got regular contraction, we've got bearing down, we've got on a cough. In this location, if they do Pilates or crunches or anything like that, you could observe or even palpate during different movements, and I haven't prepared Claire for that. Mm-hmm. But you could do that too. Again, questioning the necessity of the contraction or of this assessment is also one of the things that we're doing. Okay, from here, we can also look at other positions. So we might look at side lying,
yep.
And I might get you facing
this way
to the left, please. Good. So from here, you can do the assessment on the right side, and so you can start in roughly the same place, and then you can work backwards. So I'm just going to make sure that, and you can work backwards. So this is sacrotuberous towards the tip of the coccyx, which is here, and you can see that I went on kind of a line because it's kind of where the ligament goes, right? And so this is kind of posterior pelvic floor. Now you don't want to start too far midline. That's it. And so you just want to be sensitive to what you're doing. Now I know that I'm using my thumb, I know that I'm getting up and under, but there's glutes, there's skin, there's subcutaneous tissue, and I'm going to go look for the bone, and I actually want to feel the firmness of the floor here. So from here, Claire can do a pelvic floor contraction, and I can feel the squeeze, but I didn't get pushed out. Okay, so she's not bearing down here. If you bore down through here, good, and so you can see the perineal descent occur there. Okay, and then you could do the cough. Good. And so even though she had some movement here, it's not particularly excessive back here. Now I did notice just on visualization, just by looking, there was some. Now you can do the right side and continue towards the front, this way. It just gets like I don't do a lot of side lying unless they tell me the symptoms are in side lying. So just pelvic floor contraction here. Good. I feel the squeeze and relax. Good. Yeah. And so even in side lying, the tissue sits differently. And so I feel like I'm starting to possibly push into the labia, and I think I get enough information through what I've done already there. Mm-hmm. Now the other thing is that you can do the left side from here. So again, you find that gluteal crease. It's going to be the ischial tuberosity. This is going to be probably the level of the perineal body, roughly. If I went midline, This is the back part of the ischial tuberosity, and now we're onto the sacrotuberous ligament as it goes up this way. And so it's all just to get a sense, and I can feel that little tender spot there. Okay, and so right here you could also use this position for imagining melting in this area and complete relaxation, which, let's face it, anybody putting their fingers in this area, even for a demonstration with full consent, it's difficult to let go sometimes. And so Claire's doing a beautiful job doing that, and that just feels less, well, I've associated it with tenderness, but it just feels...
It's less tender and less tense to me.
Yeah. Good. And so then we can come this way and then go up through the pubic ramus. And again, I would start on the anterior portion of the pubic ramus and then come medial this way so that I'm not on top of the labia, but pushing the labia to the midline to get to the floor. So this is where that would be. Now what's interesting on Claire is that I can feel the pelvic floor here. It just feels more active here compared to up here, which just feels like it's more relaxed. But I don't know what it feels like to you, Claire.
Doesn't feel like anything to me.
So it doesn't feel like anything. Good.
No.
And so then you can contract there and then relax. Nice. So breathe in, relax, breathe out, contract. Good. And then relax, let it go. I want you to breathe, breathe in, breathe out, relax, breathe in and contract. Good. And let it go. And so for you, Claire, I can sense that right at this point here and then up higher, you could continue the contraction just a little bit higher to the front, to the anterior.
Yep.
So try again. Nice. That's good. Excellent. All right. We can do prone. Prone is just the same again, which is going to be feeling from the tip of the coccyx down to the ischial tuberosities. In prone, it's only for the posterior pelvic floor. It's too difficult to get to the anterior pelvic floor, and you can get to it in other ways. You could theoretically do 4-point kneeling. I very rarely do 4-point kneeling. I have done it quite a few times, but it's because it's associated with something that's going on in 4-point kneeling. And honestly, people with prolapse symptoms or incontinence tend not to report 4-point kneeling as a problem, but in the rare cases that they have, then I look at them in those positions there. All right, we'll set up for the standing assessment and then we're done.
Okay.
Okay, so this is the standing pelvic floor assessment, and what we're going to do is the same sort of thing. We're going to do the unilateral, the bilateral, and the self-assessment, or the midline and the self-assessment. So, usually again, gluteal fold will take you to the ischial tuberosity, and then from there, you can come up this way. I like to find the tip of the coccyx because just inferior anterior to that will be the anus, okay? So you can follow this way up to the posterior pelvic floor. There's the sacrotuberous ligament there. Now, how does that pressure feel, Claire?
Firm but comfortable again, and not to a point, broad.
So a broad, firm, but comfortable palpation. Okay? Now I am not midline. I can go here, squeeze your pelvic floor for me, please. Very good, and relax. You can do the same thing. You can bear down here. Can you bear down? Very good, and relax. I can feel it. Cough for me, please. Good. So in standing, she actually holds really, really well back here. There's no descent where I am. but I could feel it further anteriorly. And then from here you could try any alternate.
I didn't see an app for that. You'll need to download one.
So sorry about that. So we can do the regular pelvic floor contraction. So do your pelvic floor contraction, please, and relax. You can do the cough. Good. So I can feel her bed down. At the front, there's descent at the front, but there's not at the back here. You can do a bearing down, which I can definitely feel here now, and relax. Let it go. And then there's also the alternate cues. So if we'd worked on different cues, you could feel that too. Now my anterior hand, my other hand, is either here at the same position as when she was lying down. Sometimes it's on the other side because I need a counterbalance to help her balance. And then from here, we can do the unilateral. So this is a posterior palpation. I'm going to join with the anterior aspect. I'll keep my fingers out of it. And this will all be on the right hand side. So I'm going to use my hands this way because that feels more comfortable for me. Again, I find adductor longus. I make sure that I'm underneath it and I am lateral. I am pulling to the lateral side. I've got my thumb on her pubic symphysis and I've got my thumb up here towards the sacrum. I am outside and then I come up to the inside of that pubic ramus and then I can feel the whole length of that pelvic floor contraction externally. So pelvic floor again, please, Claire. And let it go. And so I have to push up and in a little bit, and then again. Good, and let it go. And let it rest down, like let that full relaxation of the pelvic, there it is, nice. And then come up from there. That's it. And let it go. So Claire was already starting from a mildly contracted state, just because, I don't know, somebody's got their hands on a perineum at the moment. Now, the bilateral is a hold like this. So then, that may be if you suspect a side-to-side difference. My thumb finds the tailbone here. At the front, my thumb finds the pubic symph for just above it. I'm currently on Claire's. And then the perineum sits between my fingers. I try to find the bones. And then we could do all the same actions again. And of course, from this handhold, we could get Claire to squat or bend over. Actually, if you could just do a hip hinge, a bend over for me. Yep. And so then we could test what's happening there and come back up, particularly if she's got some load, she's picking it up off a chair or anything like that. Now, there is another handhold where I take the whole of the perineum front to back to feel what's happening in terms of coughing or bearing down. This is particularly useful for feeling a change in the contraction and the effect on bearing down for SUI or for prolapse. Okay, so you're okay for me to do that, Claire?
I am.
Very good. So again, I get situated in a similar way, but this time I keep my fingers together and there's no curling of the fingers because I am midline. The labia will be shut over anyway in most people. So there shouldn't be any inappropriate contact and Claire can stop me at any time. So we're going to go start. I usually start here, down below, and you can see, hopefully, that my hands are down here. I lift up and make contact. So my posterior hand is here, my anterior hand is here. I have my thumbs in the same sort of position because I like to feel what the whole pelvis is doing. And then I'll ask Claire to contract and let go. Nice cough. Good. And I can feel that anterior contraction, or the anterior bearing down and then bearing down. Yep. And let go. and then any altered change in her pressure. If you bend forwards, I just go with her pelvis. So keep going. And you can see that I can stay with her pelvis and come back up. And so if she was doing a kettlebell deadlift, for example, I could do that and feel what her pelvic floor is doing. Okay, so that's that there. And then Claire can then do her own palpation. She can do it front to back like that, or she could do just the anterior hand only, it doesn't really matter. And then she could do the same thing. So you could do the pelvic floor contraction, she could do the bearing down, she could do the coughing. And I could also be there to help guide her if she couldn't feel certain things. But it tends to be the bearing down that's the most important information, so that people can self-assess while they're doing something like carrying their baby or picking something up off the floor. All right, if you have any questions, let us know. You can also do the self-assessment in supine, which we forgot to film, but it's the same process. You just ask Claire, you prop Claire up with pillows, and then you'd ask her to feel over the external part of the perineum with a closed hand, like so. Okay, thanks very much.